Hi everyone, it's Mr. Retracted, also known as the Wax Whisperer. Thank you for tuning into my latest video. So the patient who attended with bilateral occluding earwax, the left ear, so the ear that you saw first, is the worst of the two. This is the patient's right ear. So with the right ear, you can actually call it semi-occluding, so it wasn't fully blocking, but it was still obscuring the view of the patient's eardrum. Now, the patient was very anxious upon attending. As a child, they had several grommets fitted, and more recently, they had their earwax removed elsewhere, and they found the whole process very uncomfortable. So they're very anxious. So prior to starting, I just had to reassure the patient, explain exactly what we were doing and how we're doing it. And we're just in the left ear here. I'm just using microsuction using a Zollner suction probe. And I'm just trying to detach the plug of wax off the posterior canal wall. So when we say posterior, we mean the back part of the ear canal. And also from the base of the ear canal, the inferior canal wall. And you can see all the skin adhesions there. So the wax is enveloped by dead skin, and you can see that by the white coating, the glossy coating. So it's enveloped itself around the plug of wax. Now, this plug of wax, although I'm trying to tease it out, it's not coming any further forwards. So it's probably lodged in the isthmus. Now, the isthmus is a narrowing of the ear canal about 0.5 centimetre away from the eardrum. Most people have it, and then the ear canal widens back out. And if wax gets lodged in that isthmus, it's very difficult just to tease and wriggle it out. So in a moment, I'm going to revert to an ear hook. That's why I always, if you watch my videos, if you are a clinical ear care specialist, you must be proficient and competent with all ENT micro instruments, not just microsuction, because sometimes you just can't use microsuction to remove earwax, no matter how you try. Some patients have tinnitus, so a ringing or a buzzing sensation in their ears, and the noise from microsuction can sometimes exacerbate that. And some people are sensitive to noise, they suffer from hyperacusis. So here we are, I'm just going to use an ear hook, and I'm going to gently insert it at the roof of the ear canal, so the superior aspect of the ear canal, and I'm just gently gliding it into the plug of wax and then rotating it and slowly bringing it forwards. So you can see here it's near the entrance now. It's quite a whopping piece of wax that I removed, and I could have carried on all day with microsuction, but it would have been very difficult to extract this. So we're nearly there. Now you know we're near the entrance because you can begin to see all the cilia, all the hair. So the hairs in the ear canal are always located on the outer third, the cartilaginous portion. And just getting that final bit of wax out, and there it is. Now, patient, as I mentioned previously, they had grommets as a child. So a grommet is a ventilation tube. It's designed to allow air to enter the middle ear, so the cavity behind the eardrum via the ear canal. In most people, the middle ear is ventilated by the eustachian tube, which is a narrow orifice that connects the middle ear, so the back of the eardrum, to the back of the nose. However, in some people, this eustachian tube, for whatever reason, is blocked at the back of the nose, which means there's no air behind the eardrum, causes a vacuum effect, and your eardrum gets sucked inwards, and it feels like you're on an aeroplane. I'm just using a Jobson horn just to mop up near the entrance, and you'll see the patient's eardrum. It is intact, but there's a lot of tympanosclerosis, which is scar tissue on the periphery. Now, to me, the umbo, so the central region of the eardrum, does look retracted, it's sucked in, but when I performed tympanometry, which is a pressure test, it actually deduced normal middle ear pressure behind the ear. We're just on the right side. By this stage, the patient was very relaxed, very comfortable with me performing the procedure. He was no longer anxious, so just using suction again. Now, this is again the virtue of an endoscope. We can see the whole ear canal. So the idea is to lift, elevate, retract this plug of wax and skin off the canal wall. And we do that just by then wriggling the wax in little concentric circles. You can see the skin on the underneath, that skin that's enveloped, and that came out much easier. Now, when we visualize this patient's eardrum, it's very different to the patient's right eardrum. So this patient has got a severely retracted tympanic membrane. So tympanic membrane means eardrum, whereby the eardrum is so retracted, it's enveloped, it's wrapped itself around the anvil bone, which we call the incus, the long process, and quite possibly also the head of the stapes. You can see that there. So on the left-hand side, you can see that bone in the middle. That's the patient's anvil, otherwise known as the incus. And just about see the head of the stapes there. So it's a severe retraction. It's nothing that I don't think that can be done because the patient's had several grommets in the past. That's that plug of wax from the left ear. Hope you enjoyed that video, guys. Take care. Bye.